Dear colleagues, I've been asked today to speak about treatment targets in systemic lupus erythematosus. The word target is used in two completely different ways. One way is to say that the target for treatment is the B cell, or the target of treatment is BLIS, or the target of treatment is interferon alpha, and that has to do with how you develop medications. But that's not what I'm going to talk about. I am going to talk about the target which we set as a clinician for our patient. What do we want to achieve for each patient? And as many of you are aware, there have been significant initiatives, mostly in rheumatoid arthritis in recent years, to say that treatment should really be targeted at the individual level to achieve a certain goal. This is not completely unique, of course. This has actually developed in other medical areas for many years. For example, the specialists treating diabetes realized that you can't just ask the patient how their diabetes is doing. You have to set a target, a hemoglobin A1C level or something like that. Hypertension specialists realized that you cannot just ask the patient, how is your blood pressure? You have to measure it and set a target. So that's what has happened in rheumatology, in some other disease areas, and now increasingly in systemic lupus erythematosus. So, again, my talk, defining treatment targets in systemic lupus erythematosus. I do have to disclose that I have received research support and consultancy from these companies. And lupus, as we all know, is a multidimensional disease. It has many different aspects. It has the heterogeneity and the long-term unpredictability, which makes it harder for us to treat it. But there are also very specific areas that we feel are important in treating the patients. And of course we want to reduce the patient's symptoms. Of course we know that we need to try to reduce the number of flares or decrease need for glucocorticoids. We want to prevent the damage from accruing, and we also believe strongly that it's important to improve health-related quality of lives. And what we really would like to achieve at some point in the future is to cure lupus, but unfortunately that is a very remote prospect at this time. So I'm going to talk to you about the treatment targets for lupus, but first I'm going to spend a little time on saying how are we doing today. Then, of course, we'll get to the question, okay, what's the target? What are our ambitions? And then a little bit of a thought about where we maybe are going to be tomorrow. So how are we doing today? Well, that has actually already been discussed at this Congress now by several experts. But I would like to show some data from a survey that we did in Sweden 1.5 years ago, which was actually in a collaboration project with the patient organization in Sweden and with a grant from Glaxo. And we went to the patients and we said, okay, so let's ask you some questions about how you're doing. And actually, one of the parts of the survey was to also get a feeling for health economics. But one of the important questions was, what is the quality of life? And this is an instrument called EQ5D or Euroqual. And it's a very simple instrument with just 5 questions that the patient has to answer. And it has been shown in many studies that it gives a very good number for quality of life. Now, for some of you, this is already known, but others might think, how can you make quality of life, which is such a big concept, how can you make it into a number? And of course you lose a little bit, but it can be done and it's used very widely. And the number can be between 0, which is a terrible, terrible quality of life, or actually like death, and then 1 is perfect quality of life. 1.0 is the best you can get. Everything is fine. And this is what you can see here, that the patients with lupus had a quality of life of 0.64 measured by 2 different methods. So that was very clearly not so good. Now, were these patients unable to get medical care? Could they not get medications? Were they outside of the society? No. These were patients in Sweden who have access to health care because it's a socialized system. There is no cost issues. Medications are in principle covered for. So if they could need a medication, then they would also get it. And they were often taken care of by specialists who really were committed to giving them the best possible care for their lupus. And yet, that is what we get, 0.64 average quality of life. It's not so good. This next number is the fatigue, which is a very significant problem for patients with lupus. And as you can see on a scale that went from 0 to 10, it actually is 6, so it's also not good. And then, of course, the issue about the cost, which was one of the things we were interested in investigating. How much does it cost society to have a patient with lupus? It's maybe not a very sympathetic way of analyzing things, but it's important because we need to know what we're dealing with. And if you add all the costs, including the direct costs, which are the medications and the hospitalizations, which is very expensive, or any other kind of medical interventions, that's already a big cost. But then if you add the indirect cost, which is to a large extent the loss of productivity, when people are so sick they cannot go to work, they cannot take care of their families, or they cannot do other things in society, then that's an enormous loss. And we get up to a number that's quite staggering, more than 20,000 euros per year in the total cost of lupus per patient. And this is an average. So the extremes are, of course, very, very striking. So in another survey that was done completely separately from the first one, this was actually commissioned and done by Adelphi, and together with Dr. Wiebeke Strand from Stanford, I had the pleasure of working with the analyses, and we presented this at the ACR Congress last fall. And this was a survey done in the United States and in several European countries, and it asks from the patients some information, and also from their physicians. And the questions were related to various aspects of lupus, including also medication use. And if we focus on the patients that were identified as having moderate or severe lupus, one important finding was that half of these patients have in fact flared over the past year. And again, because of the way the survey was done, these were patients who were in contact with a specialist. So they were under the care of a specialist, maybe one of you or one of us, and still they flared. And we all try to avoid it, and we try to make sure it doesn't happen. We're just not very successful. But we also found out something else in this particular survey, which I want to mention to you. When you asked the physicians how happy they were with the results of the treatments, this is what they answered. And again, if we look on the right side, for the patients who had moderate or severe disease, half the patients said they were satisfied. And 1/4 said, well, I'm actually not satisfied, but I don't think there's any way that it can be done better. This is what we have. And there was 1/4 that said, actually, I'm not happy, and actually I'm going to do something about it. I'm going to find a better treatment for this patient. And for the mild patient, it was overwhelmingly satisfied with the treatment. But this was a bit strange to us because, in fact, in the remainder of this survey, we noted the same things that we found in the Swedish survey. These patients weren't doing so well. They did have reduced quality of life. They had flares. They had disease activity. They were also on a lot of medications. And yet the physicians said mostly that they were happy with it. They thought it was okay. We thought that was strange. So we asked the patients, but that's actually not on this next slide, but if we asked the patients, we got a very similar response. So the patients didn't differ so much from the physicians. So they also said, we're sort of happy with this. So we couldn't understand it. So we tried to figure out what was going on. And part of the explanation may be that if the patients are, told they have lupus, and now they're going to get the best treatment there is, and 10 years later, they're not doing so well, but they've been told all along that this is, these are the treatments that are available. Maybe they have given up a little bit. Maybe they have come to the conclusion that things will just never get much better. So they say, yeah, I'm happy with it. And so do the physicians. So I think there's a sense when you look through the results of these surveys that we accept maybe a situation that's not 100% as we would like it to be, just because we don't really believe it can be improved. So where we stand today is I think that at any point in time, if we look at our patients, many do have disease activity and they are at risk for flares. Their quality of life is reduced because of the disease. Their prognosis may not be so good, and you've heard the other presentations where there's still a considerable long-term morbidity and mortality for lupus. And yet we are finding that physicians and patients also are saying, yeah, I'm actually okay with this. So, and so we need to really examine our assumptions and our attitudes. And that gets to the second of my questions. What should our ambitions be? Now, as I already mentioned, there have been several initiatives talking about targets in rheumatic diseases. And so we, with a group of mostly European rheumatologists interested in lupus, but some of the other parts of the world, gathered to discuss the treat to target in lupus. And this was done at several meetings in Zurich, in Switzerland, over the past year. And the group is rather large. Here are all the participants, to the extent that they were able to participate in all meetings, but many of them were. And in addition to the actual meetings, we also had a lot of contact by email to try to arrive at some sort of consensus for treat to target in lupus. And this is still a work in progress, so it's not finished yet, but we hope that within the next few months we can finalize a document that is based on the literature, so it's not just our opinion, but it's based on a very thorough literature search, and that was actually the algorithm for the literature search that was in turn based on the questions that were most important and most instructive for this topic. And this search and the analysis of all the articles, and you can see that even at the end of all this you have 440 articles plus 60. This was done by George Bertsias from Greece, who did a fantastic job on the literature search, and then through this whole large committee we further analyzed these results. And so with the treat to target group we have now achieved that some consensus. In the meantime, the European Medicines Agency has been working from a completely different angle. The European Medicines Agency is of course the organ that controls whether medications can be approved or not, and they understand that to get approval for a medication you have to do a clinical trial. So then the question comes up, well, how should you do the clinical trial in order to get a drug approved? And they said, okay, we'll make a document, a guidance document that says what we think you should be doing. And the EMA doesn't do this by themselves. They ask all kinds of experts, maybe some of you, and they say, okay, how should we do this? What are the recommendations? And they have now issued a guidance document, which I think is not fully finalized, but almost. And the two initiatives, the Treat to Target initiative from the experts asking how do we treat the patients, and the EMA initiative, which asks how should we do the clinical trials, were actually remarkably similar in their conclusions. So what the preliminary results of both of these initiatives are saying are that the objectives of lupus treatment has to be to reduce the disease activity and ideally to induce a state of remission. This is of course what we clinically also want. The patient should not have symptoms. There's some discussion if the remission is a full remission, if it's only clinical or does it have to be serological. There's some discussion what medication is allowed to call it a remission. But in principle, we feel that the disease activity should be targeted as being absent. As a second target for the treatment, there's the prevention of flares, or if that's not possible, then a longer time interval between flares. And again, the EMA document says these are also outcomes for a clinical trial. Prevention of long-term damage is extremely important because, as you know, the long-term damage in lupus, which can be measured best by the SLE damage index, is not just a marker for how the patient is doing today, and of course nobody wants to live with damage, but it also predicts further damage, morbidity, and mortality. So prediction of long-term damage is extremely essential, and again this can be a target in the daily care of the patient, but also can be an outcome in trials. To decrease the cumulative exposure of corticosteroids is very, very obvious to all of us who are clinicians or patients, and that we realize that although corticosteroids can be life-saving, they also stand for a lot of the problems that we see long-term in the management of lupus. Finally, in the Treat to Target document, it was clearly stated that improved health-related quality of life has to be a target of treatment, but that's really for the physician in connection with the patient. Whereas for a clinical trial, which EMA is dealing with, that is not considered at this time to be sufficiently robust to use as a target in a trial. But for daily practice, that would certainly be very appropriate. What's not in these two documents is to cure lupus. Sadly enough, I think it's still too far removed from the possibilities to have that as a target. But it will be at some point in the future. And so then the question is, where will we be tomorrow? Because I told you that we're not quite there yet. The patients are not doing so well, but we can identify at least the target so we know what our ambition is. And one question that comes up then is, how about the biologics? Are they going to be helping us in this regard? Are they going to change the treatment paradigm? And if you've heard me speak before, if you know me, then you know that my answer to that is of course yes, because I think the biologics are really impacting now on lupus treatment. It hasn't been like that for very long, and I think we're all getting used a little bit to the thought that, okay, biologics are really here in lupus management, but it's certainly happening. And I did spend some time deciding on which kinds of data I would show, and not all of it is positive, but some of it has already been shown here at the meeting also, including this morning. So we do have some negative trials, but we also do have some hints at positivity. This was from the abatacept trial with ostensibly negative, but in a subset there were some suggestions. And then with the belimumab trials, the improvement in anti-DNA and the clinical improvements, so that we think there is in a set of different trials some glimpses of what we can achieve and some actual accomplishments. And finally, that we can begin to selectively use biologic treatments for the right kinds of patients, for example, by identifying some predictors of a good response to, in this case, belimumab, where it is clear that anti-DNA and low complement will identify patients who have a higher likelihood of responding to this particular biologic. So with that, I would like to summarize and say that the treatment of lupus still remains a major challenge. But we do have evidence now that tells us that there are some things that have to be changed and some things that can be changed. So overall, the results are not totally satisfactory, and we need to accept it and we need to face it. And if we say that we are satisfied, we need to understand that it's in part maybe because we haven't really kept on believing in the possibilities. But if we now recognize what's possible and we look at our patients and say, okay, we can do a little bit better for you and for you and for you. And we target the treatments so that we have a clear goal for what we want with the patient, but it has to take into account the different aspects of the disease. And I do think biologics will give us new opportunities and will us help, together with the patient, to achieve these goals. Thank you very much. I will stop here. Yep.